Thought leaders participating in this program are speaking on behalf of Lilly. They are compensated for their time and expertise. Any opinions expressed in this podcast reflect their clinical experience and expertise. Welcome to Neurizons, the podcast where we hit the road to explore Alzheimer's disease and the goal of maintaining brain health, one conversation at a time. I'm Bert Vargas. I've been a neurologist for over 20 years, and now I'm cruising across the country, chatting with some of the brightest minds in the fight against Alzheimer's disease. No formalities, just honest conversations with thought leaders, innovators, and advocates, all aiming to crack the code on preserving cognitive health. In this episode, I'm talking with Dr. Dani Cabral, a dual board-certified neurologist and psychiatrist specializing in Alzheimer's disease and dementia care. She's also the founder of Brain Love, which uniquely combines holistic and medical strategies to support those with cognitive decline. We tackle key questions like, what insights have clinical trials targeting modifiable risk factors provided? And how do trial design and patient demographics shape future treatments? We also look beyond the US to see how Scandinavian countries approach brain health and what we can learn from them. So join us at the intersection of research, care, and global perspective, and see how all of it is shaping the future of brain health. Welcome to Neurizons. Hop in and let's talk. Dani, thanks a lot for joining me today and giving up a Saturday. I don't think a lot of people necessarily know that you are double board certified, right, in neurology and psychiatry, but you were also part of the very first class to graduate from the University of Arizona College of Medicine in the Phoenix campus, right?
Yep.
That's fantastic. And you're now a pretty well-established subspecialist in dementia in Alzheimer's, correct?
Yes. I eat, breathe, and sleep Alzheimer's disease these days.
Wow, that's a lot of work. I know it's a pretty large population, but it's also a relatively older population in many respects.
Right. It's the perfect place for me.
So that's a perfect lead into the fact that's really what we're going to talk about today. We're going to talk about dementia and Alzheimer's and about risk factors and maybe even some of the interventions and the intervention studies that have shown some interesting impacts on someone's risk for developing dementia or Alzheimer's. But it would be wrong to dive into that right away without talking a little bit about you. What would you normally be doing on a Saturday like today? Are you a big mountain biker?
Yeah, well, this was my midlife hobby that I've taken up.
Yeah.
It's really been important for me, and I actually also relevant to brain health. This happened like when I turned 43. Like I was like, I need to step it up. Biking is a great hobby, and it's been so wonderful, and I've met wonderful people in these groups.
Tell me about your mom and
Sure.
maybe how that experience when you were 17 kind of shaped the direction your life took.
That's been the major event that I go to, like before that, after that. So my mom was a single mom, and she got ovarian cancer when I was a junior in high school. She was diagnosed, and then she died a week before I graduated from high school. And my sister was already in college in her first year. So that was really, of course, earth-shattering. And through that experience, I learned lots of things. But really, I think with grief, that when someone's going through difficult times and losses and challenges, it humanizes all of us, and we can connect on that level. Often people don't realize what's like the little changes that are happening in losses and how it's affecting them and their identity and relationships, and how their people in their lives, it's affecting them as well. So like the family members and friends. And so I try to create space to just at least acknowledge those things, right? Which in our short time in the clinic, because that allows people, they can take that, I plant that seed, and if they want to talk about it in the room, fine. If they don't, they often will come back and say like, they were able to process that a little more and come to, it could be a whole number of things, but it's really, I think, not something that the healthcare system necessarily notices or values now, but it can be therapeutic for patients and families to have that time.
Definitely.
what I say is that if you're a healthcare professional and you feel dehumanized, you'll probably accidentally dehumanize your patients because you're just like, gotta keep moving. I gotta do my job. And I think some of these multimodal interventions for say brain health are sort of a good example of an ideal way to do this, although having the ability to get counseling on diet, exercise, social interaction, cognitive stimulation, vascular monitoring is amazing. Though I don't know, that would be a systems change for us to do that.
How do you do that and actually get someone to take action on it? Because that's not easy.
Yeah, great question. Well, we know that, and especially over the last 5 years even, there's been so much more data and so many good quality multimodal intervention trials that show that things like exercise, especially exercise, clearly have an impact on brain health, sleep, even with neuroimaging studies showing that increases cortical volume. So real biologic changes. What I do is I convey this information to them about the science. What do we know? At this point, we have a rapport, they trust me. And with people who are having cognitive impairment, I would say something that I always do is I remind them, I say, I'm a memory specialist physician, and I know you are a retired engineer and you love golfing. So I just want to mention that important piece is because that it's up to us as people are experiencing these diseases to help them remember who they are. And that little bit goes a long way because then they're actually listening to me. They're like, oh, I kind of like her. She knows me, when they're otherwise walking around the world scared, maybe like I should know where I am and I don't. So that's a whole other piece. But so the multimodal interventions have commonly used, and I will speak to the most well known is the finger trial coming out of Finland. And so that was a 2-year trial of multimodal lifestyle interventions for people who are at risk of developing dementia. So things like mainly like cardiovascular risk factors and age. And so that incorporated 5 areas like a hand, finger. So exercise or physical activity, diet, cognitive stimulation, social stimulation, and vascular risk factor optimization. So this was a 1-to-1 that versus some basic education. The people who got the intervention had even improvement in certain areas of cognition and overall their global score and areas of, say, I believe, working memory, executive function, for sure. And executive function, so as you know, planning, multitasking, organizing. But that's really a key part of how we function in our lives is to be able to, to have good executive function. And so how do I talk to people about or try to motivate them to take action? So I firstly am very intentional explaining, well, why do you want to bother with any of these things? And then giving precise recommendations that are doable to start. That's so important. So like
baby steps,
small changes. Right. And that's been shown in a study, the Exert trial with Laura Baker, that it's really about the consistency that makes an impact.
You mentioned like the finger study.
Yeah.
Which was a Scandinavian study, right? Mm-hmm. I guess have some of those principles and some of those ideas for research, have they made their way to the United States yet?
Absolutely. There's been a few similar trials that have shown in a short duration there can be some benefit for people who are at risk of going on to develop symptoms of, say, Alzheimer's disease.
Sure.
And so there's been a recently published study by Dean Ornish, the Ornish cardiology. So they did. So they had people who were with mild cognitive impairment who did a multimodal intervention over 20 weeks that showed some definitely stability and then some small improvements in different areas of cognition. And again, this was like with diet, exercise, including there were supplements, there was vascular monitoring. And so that did show benefit. But really what we need is, longer term being able to do this. So it is absolutely starting to infiltrate the consciousness of the US. So those finger studies came from Finland. And so the Scandinavian, the Nordic countries are definitely farther, I would say much farther along in this area of Alzheimer's and brain health than we are. Probably a big reason for that is their culturally, they're much more of a collective, and there's more, there's socialized healthcare, there's more education, the public, the government supports this program. There's more spaces to engage in these exercise programs, green space. There's more multi-generational activities that are already embedded in the culture there. And so I think the U.S. has a bigger challenge with some of these things because we'd really have to work on changing our communities. But I hope that we can do that.
Are you finding that there are certain groups of those patients or certain populations or maybe even genetic risk factors that some might have that maybe suggest that they would do better with some of those recommendations of yours?
Yeah, what's interesting is that consistently in these multimodal interventions for people at risk of developing Alzheimer's disease symptoms, a population that consistently shows benefit are those who have more cardiovascular risk factors to start. And so that's huge, right? And so the U.S. Pointer trial, which is going on now, and that's our multimodal intervention version of the finger trial. So they're specifically, they've recruited for people who have more cardiovascular disease, and so who are at greater risk, but also appear to, we hope, have more of a benefit from these interventions. And I think that's huge and generally needs to be more publicized because, as we always say, what's good for the heart is good for the brain. And so we really want to connect with our primary care providers and figure out how can brain health be more incorporated into those visits, because they're already talking about heart health. And so to communicate with patients and counsel patients that it's all connected, our blood vessels are going through our whole body, there's even more understanding of vascular health in the brain. And I might personally start talking more about neurovascular health, like cardiovascular health, because I think the public will understand that over time. And I think that's really meaningful to demonstrate, it's all connected. But that's really a major population that's benefited from these interventions. And then the APOE4 carriers in some studies seem to have somewhat more of a benefit from these multimodal interventions. There's so many things that can benefit people right now and that's what really the focus should be. And so, of course, I'm always hopeful and motivating with my patients that, your life is happening right now. Like you can make it better right now with these little things.
And when you talk about risk factors, what are some of those big risk factors?
The Lancet Commission just was published in 2024, the most recent one. And that's a great paper to look at because so some of those risk factors are hypertension, obesity, smoking, social isolation, depression, hearing loss, air pollution, low education, alcohol use. New for this publication, 2 new ones were vision loss and high LDL, right? And this really, when does this happen? When do these really make an impact? It's midlife. Yeah. So I love the question. I love to ask, so what do you think, when is midlife? Like, when would you say that is?
I'd say it's pretty much whatever age I'm at the moment.
Okay, fair enough. All right.
It's a moving target for me.
Well, I would say, I usually think 40 to 60 is a good range.
Yeah.
And if we could get the word out to people that were in those age ranges that these things make a huge impact. And the way it is laid out in the paper is nice because it talks about which of these risk factors occurs in early life versus midlife versus later life. When do they impact that risk of dementia more so? And a bulk of them, most of them, are in midlife. And as we know about Alzheimer's disease, this is when the Alzheimer's brain changes are starting to happen 20 years before there's any symptoms. So we know the amyloid starts building up 20 years before, and then the tau closer to when the symptoms start.
You know, the other thing that you said earlier that I wanted to get back to was when you were talking about, I think, vision loss as a risk factor, but also hearing loss.
Yes.
Right. Mm-hmm. And I think there's a lot of people that may not understand how that link happens. Right. Is it a shared biology that kind of links dementia to hearing loss, or is it actually that the hearing loss contributes to that social isolation that then contributes to dementia? I mean, how does that work?
So we don't know, but basically it's both. So it's that I think we think that that sensory deprivation, so your brain's not getting stimulated, as in ways that we don't. It's on an unconscious level that our brains are getting stimulated by all sorts of visual stimuli, every sense, frequently, and then so there's less of that, and so our brains just get weaker. Essentially, those neural connections get weaker, and likely the brain starts atrophying and things like that. So, and then the one is less inclined to go out if you can't hear, you can't interact. So there's a loss in that way of those interactions and that all of the stimulation that occurs with those activities that you're foregoing. So then everything's just like shrinking. Your brain and your world is shrinking at that point.
Yeah.
Yeah.
And when you talk about, again, with multimodal interventions, I feel like there were so many times when I would try and make numerous changes to the lifestyle of a patient. I remember a lot of times they would come back and they would say, well, I appreciate that you're doing all these things. You're adding all these treatments, but also making all these lifestyle changes. How are we going to know what's working, right? How do we know what the what's actually making the difference for me?
Yes. I will take a phrase from Dr. Aliatri, which is that you can't blueberry your way out of this. So what I say is we get more and more unique and fascinating and as we get older. And that's why I like working with older people, because they're all so different. They've all gone on their own paths and have all these different factors influencing who's made them who they are. And so that's why. So it's taken decades of unique experiences and genetics to get to the point you're at. And so it's one thing is never gonna be the solution to what's going on. So it's going to take multiple things to get at this, because it took multiple things to create it.
Well, Dani, I really can't thank you enough for joining me today on a Saturday and taking you off the mountain bike for the day.
Wow. Well, thank you. What a fun conversation. You had such good questions, and I love talking about this stuff. It's so important. And if we don't talk about things like this, and if we don't do things differently, nothing is going to change in brain health.
Oh, I see you as an enormous part of that change. So thank you for doing what you're doing. And thanks again for joining me today.
My pleasure.